Hello and welcome to our discussion of questions on diabetes. Our questions today will be divided into two sections. We'll have the first section on DKA and the second section will just focus on the rest now. This is Dr. Mumbi from Medes Academy and let's get started. First question, we have a 22-year-old female with type 1 diabetes presenting with abdominal pain, nausea and vomiting. Their blood glucose level is 25 millimoles per liter, and their arterial blood gas shows a pH of 7.25. What's the most likely diagnosis? So, in a setting like this where we have a patient with type 1 diabetes presenting with a pH like this and abdominal pain, nausea, and vomiting, you are most likely dealing with DKA. So this is a typical presentation of diabetic ketoacidosis. They'll present a scenario of a patient who has type 1 diabetes. Then this patient, in most cases, will present with abdominal pain, nausea, and vomiting. And then they might tell us what the pH is. Sometimes they might not even tell us. They might tell us what the glucose level is. Sometimes they might not even tell us. So that is up to us to know. In most cases, what just sells this type of question is the fact that you're dealing with type 1 diabetes and then the patient is coming with abdominal pain, nausea, and vomiting. Sometimes, actually, the patient will not even be able to talk. Sometimes the patient will be in a coma. Sometimes the patient may not be in a coma, but they'll tell you that the patient is really tired. Sometimes the patient will come with some level of confusion because they are vomiting and they are probably losing a lot of fluid through both vomiting and also a lot of urination, because when the sugars are high, there's going to be quite a lot of urination. Remember, polyuria with diabetes, you have polyphagia, you have polyuria, you have polydipsia. So in most cases, they'll come like that. They might come with signs of shock. Okay, so that is how you know that you're dealing with DKA. But a case like this where they've even told us that the pH is 7.25 and the sugars are that high, then we know we are dealing with DKA. If you notice the options, they've given us another complication, acute complication of diabetes, which is HHS. But HHS is mostly common in type 2 diabetes. When you look at the other types of acidosis that we have, lactic acidosis and alcoholic ketoacidosis, those are not, they're just there to confuse us. They've just been thrown in there because they know that when you see 7.25, you know that, okay, you're dealing with acidosis. So you might be confused by options B and option E. But really, the answer here is diabetic ketoacidosis. Acute pancreatitis will present with severe abdominal pain, but this pain will be radiating to the back, and then they'll tell us something about their lipase, serum lipase levels, or serum amylase levels, because those are the enzymes that are disturbed in acute pancreatitis. So here we are dealing with DKA, option C. All right, let's look at another scenario. So option 2, which of the following is a characteristic lab finding in DKA? High serum bicarbonate, no. Serum bicarbonate is low in DKA. Low anion gap, this is not correct. Anion gap is high in DKA. High serum ketones, yes, this is a good one, but let's wait and see. D, low blood glucose, no. Blood glucose is high. It's a case of hyperglycemia. E, normal serum pH. The name itself says acidosis, so the pH is low. It's acidic. So that is how you analyze that question. So option C is the correct one here. Option C is the correct one here. Okay, and feel free to pause the video if you want to get a much more clear understanding of what the text is saying. What is the initial fluid of choice for rehydration in a patient with DKA? So this is a good question. Usually the one that is used clinically is 0.9% saline. So 0.9% is what you're going to start with in DKA. So normally the core principles of treating DKA are you need to resuscitate, so fluid resuscitation, then you need to use insulin at some point, but also potassium is very crucial. Yeah, so potassium is another important aspect to consider. You might need to administer potassium. You will need to administer potassium at some point, especially when you start giving insulin, because insulin will start driving potassium into the cells. Then you need to also give antibiotics, because usually what tips the patient into a case of acidosis is some form of infection. I'm sure we'll come across a question that will ask something like that, but I just wanted to make those things clear, the key principles. Okay. Question 4. In the management of DKA, when should IV insulin be initiated? So this is another good question, okay? A, after correcting serum potassium to 3.3 milliequivalents per liter. B, immediately upon diagnosis. C, after normalizing blood glucose. D, only if there is no improvement with fluids alone. And E, when bicarb therapy is started. All right, so for a question like this, this is a very practical question, because clinically when you're treating, you need to know when should you start your IV insulin. All right, so remember what I told you about potassium. Normally, the ideal thing to do is to correct serum potassium to somewhere around at least 3.3 milliequivalents per liter before you initiate. So the idea here is hypokalemia is a life-threatening condition. So that is the ideal thing to do. So option A, first you correct your serum potassium to at least 3.3 milliequivalents. And the idea is you want to avoid hypokalemia. Okay, question 5. A patient with DKA is being treated with insulin and IV fluids. His blood glucose drops to 250 milligrams per deciliter. And we're being asked what adjustment should be made in this patient's treatment. Okay, so another really good question. You are treating a patient, and you are giving, remember what I said, insulin, then fluids, very important. Yeah, insulin and fluids, those two are being administered. Then as you're administering, the blood glucose keeps dropping, because the fluids themselves are kind of diluting the plasma, but then also insulin is driving the glucose into the cells. So the levels keep dropping, and this is what you want. Now, there's something crucial that you need to do when sugar levels drop beyond a certain point. In this case, 250 milligrams per deciliter, which is about 13.8, 13.9. Let's just round it off to 14, okay? 14 millimoles per liter. That's the equivalent of 250 milligrams per deciliter. So 14 millimoles per liter. So when it falls beyond that, there's something crucial that you need to do, okay? What is that? When it falls to, not necessarily when it falls beyond that, when it falls to that, when it drops to that. So what you're doing is you're monitoring the levels, okay? 16 millimoles per liter, 15 millimoles per liter, 14 millimoles per liter, 13 millimoles per liter, thereabout. What are you going to do? A, discontinue insulin infusion. Do you discontinue? B, switch to subcut insulin. Is it at this point where you switch to subcut? C, add dextrose to IV fluids. D, increase insulin infusion rate. E, discontinue IV fluids. Okay, so at this point, what you need to do is to add dextrose. All right. So in other words, at this point, you'll be giving insulin and you're also giving sugars. The idea here is you want to avoid hypoglycemia. Okay. You want to avoid hypoglycemia. That is why you add dextrose. You don't want the sugars to plummet to dangerous levels again. Yes, you were correcting sugar levels, but if you are too aggressive, you may tip the patient into hypoG, and that is what you don't want. So at that point, it's a crucial step, it's a crucial intervention. You start adding dextrose. Okay. Question 6. Which electrolyte imbalance is commonly seen in patients with DKA and needs to be closely monitored? Which electrolyte imbalance is commonly seen in patients with DKA and needs to be closely monitored? So we've somehow hinted at this. The electrolyte imbalance that you'll find, which one is it? Is it hypercalcemia, A? B, hypophosphatemia, C, hypernatremia, D, hypokalemia, E, hypermagnesemia. So an electrolyte imbalance that is expected here is hypokalemia. Okay, again, remember that insulin, when it's given, actually insulin is also a good way of correcting potassium levels. So sometimes when you have a case of hyperkalemia, you can give insulin together with dextrose to drive potassium into the cells. And the reason you're adding dextrose is you don't want to tip the patient into hypoglycemia, similar to the previous question. So hypokalemia is a serious consideration here. You want to avoid it at all costs. Okay, so hypokalemia. 7. What's the primary mechanism causing metabolic acidosis in DKA? So how do we even end up having DKA? A, increased lactic acid production. B, renal failure. C, accumulation of ketone bodies. D, respiratory acidosis. E, diarrhea induced by carbonate loss. So here, the body switches to the use of ketones for energy production. So you're going to have an accumulation of ketone bodies. Option C, an accumulation of ketone bodies is what will lead to this. Okay. Question 8. Which of the following is a common precipitating factor for DKA? A, hypertension. B, hypothyroidism. C, infection. D, hyperlipidemia. E, anemia. So notice how the question is asking us to state something that precipitates, okay? Something that forces the patient to go into DKA. So normally what happens is you would have a patient with type 1 diabetes. This patient is even taking insulin. They are okay, but then all of a sudden they go into DKA. What is it that has pushed them into that state? That's what the question is asking. So there's something that pushes the patient, tips them into DKA. And in most cases, it's an infection, okay? And that's why under the principles of managing DKA, you have antibiotics. Normally, you just treat it empirically because you're not sure what you're dealing with, but antibiotics are there. So infection is a common precipitating factor, okay? Question 9. What's the primary treatment goal for a patient presenting with DKA? What are you targeting? A, normalize blood pressure. B, correct acidosis and ketosis. C, reduce serum cholesterol. D, treat an underlying infection. E, prevent hyperglycemia. So this is another interesting question, very practical actually. But what is it that you're targeting? Okay, there are some options here that are just making noise. Well, in most cases, the blood pressure will be low, and yes, you'd want to correct it, but that's not the primary problem. Okay, serum cholesterol, this is just making noise here. Yes, we did mention that there will be an infection. Most likely there will be an infection, so you want to treat it, but that's not the crucial point at this phase or at this point. And treat hyperglycemia. Yes, the patient is hyperglycemic and you want to correct that, but what you really want is to correct acidosis and ketosis, because that's what's responsible for this state. You want to move this patient from a state of acidosis and ketosis. Okay, so that's your primary treatment goal. That is your primary treatment goal. Which of the following clinical features is indicative of severe DKA? So what will indicate severe DKA? Clinically, A, glucose level of 10 millimoles per liter. B, serum bicarb of 22 milliequivalents per liter. C, blood pH of 7.1. D, mild ketonuria. E, absence of Kussmaul respirations. Okay, so we want something that indicates severe DKA. Let's just rule some things out. E is just there to make noise, okay? Because when Kussmaul respirations are absent, then you are feeling nice. You know, the patient is stabilizing. Remember how another typical presentation of DKA is that they'll come with what we call Kussmaul breathing. So Kussmaul breathing is where the patient has deep and quick breaths. So they are deep and they're quick. That's what you find in Kussmaul's breathing. So that is the absence of that is a good thing. Normally, another way they will present this case to you is they'll tell you this patient came with abdominal pain and they were vomiting, they were nauseous, the blood glucose was high, the pH was low, and they came. Their breathing pattern was typical of Kussmaul's breathing, the one I've just described here. And then they'll tell you that the patient's breath had a sweet smell, okay? Sometimes they'll say a fruity smell. So that is the smell of ketone bodies. So these ketone bodies, the ones that are responsible for this, they kind of have a sweet smell. So that's another thing that you'll find in the description of such a question. So let's get back to this. So E is out. Ketonuria, yes, you are worried about ketonuria, but notice how it's mild in this case. So it's not really a big concern. Serum bicarb of 22, this is normal, okay? This is normal. Option A, blood glucose of 10, you're not really worried about that, okay? It's not that big of a problem. The big problem here is, notice the pH. The pH is 7.1. The normal is 7.35 to 7.45. So when it's 7.1, this is way too low. The level of acidity is quite high in this case. So that is your primary concern here. That is what is showing you that, okay, here you're dealing with severe DKA. You need to be quick, okay? You need to be quick. So metabolic acidosis there indicated by a pH of 7.1. That's your sign. That's your sign. So let's go to other questions now. Which of the following is the primary autoimmune target in type 1 diabetes? So what is really targeted in type 1 diabetes? Remember how type 1 diabetes is an autoimmune type of disease, okay? Something is targeted by the body's own defense mechanisms. What is it? Insulin receptors, the one that has an issue with insulin resistance and all that is type 2, okay? Pancreatic alpha cells, yes, it's related to the pancreas, but what type of cells? Is it alpha cells or some other type? Let's wait and see. Glucagon receptor, not really. Pancreatic beta cells, okay. So we have two pancreatic cells. Let's put them aside. Somatostatin, oh, for some reason I failed to pronounce that. Somatostatin receptors. This is also just making noise here. So the real answer will be between B and D. Is it pancreatic alpha cells or pancreatic beta cells? And you're going to find that it's actually pancreatic beta cells. So the body targets pancreatic beta cells, destroys them. When they are destroyed, the person lacks insulin. So you have a case of either reduced insulin production or absolute lack of insulin production, absolute deficiency. That's why with type 1, you just need to give insulin because there's no replacement. With type 2, you can give drugs like metformin, those that will just help the body use the insulin that's there, because the problem is not with production of insulin, it's with how this insulin then is received. How sensitive is the body to this insulin? That's the question. But with type 1, it's a matter of absence. So that's the understanding there. So they'll give you things like this, and yes, it's the pancreas, but which type of cells exactly? All right. Which of the following is a common presentation of type 1 diabetes mellitus in children? So it's exactly what we've been dealing with. Type 1 diabetes mellitus, the commonest presentation is ketoacidosis. We are just from dealing with questions on DKA. Question 3, which of the following antibodies is commonly tested in the diagnosis of type 1 DM? So with type 1 diabetes mellitus, remember how we said the body is targeting its own cells, the beta cells of the pancreas are targeted. But what antibodies are you really testing for in order to confirm that there's type 1 diabetes? So A, anti-insulin antibodies, B, anti-GAD65 antibodies, C, anti-thyroid antibodies, D, anti-nuclear antibodies, E, antimicrobial antibodies. So here, the correct answer is B, anti-GAD antibodies. So they are the ones that that will be present, they are the ones that will commonly present in patients with type 1 diabetes, and they're the ones that are used as a marker for autoimmune beta cell destruction. Question 4. What is the most common? I just showed you the answer there, didn't I? What's the most common initial treatment for type 2 diabetes mellitus? So initial treatment for type 2, I've already hinted at this. You don't necessarily go with insulin, all right? The body has insulin. You just have to find a way of helping the body use that insulin, okay? That's an easy way of understanding this. You want to help the body use that insulin. That's why with type 2, you tell the patient to find ways of improving their insulin sensitivity. Even ways of preventing that could include, being physically active, reducing on your weight, those things that improve insulin sensitivity. So you give metformin, okay? Metformin is a first line. It's a first line pharmacological agent. All right. 5. Which of the following is an acute complication of DM? Acute complication. So retinopathy, this is a complication, okay? Nephropathy, it is a complication of diabetes mellitus. DKA is a complication of diabetes mellitus. Neuropathy, good option. It's a complication of DM. Cardiovascular disease, this is a complication of DM. But notice how we're considering acute complications. So we are interested in the acute complications. So retinopathy, nephropathy, neuropathy, and CV disease, these are chronic. They happen in the long term. In the acute setting, DKA is what you come with. Is what you're going to notice, rather. So diabetic ketoacidosis, all right. So characteristics: hyperglycemia, ketosis, and metabolic acidosis. We remember the questions that we did earlier. Question 6. Which diagnostic test is used to monitor long-term glucose control in diabetic patients? So long-term glucose control is going to be indicated by what we call HbA1c, okay, glycated hemoglobin. So this is very important. It's very important to know. So glycated hemoglobin is what will show how the body has been dealing with sugar control for over the last 2 to 3 months. That is the test that you use. Among these, it's fasting blood glucose that doesn't show. Remember, our focus is we want to see long-term glucose control. We are not looking at the present, how the sugar levels are at the moment. No, we want to know how has this patient's body been controlling blood sugar for the last 3 months. Okay, that's our focus on that. So HbA1c, yeah, and it's important to remember how this is working, because you have some sugar that is bound to hemoglobin, okay, and because hemoglobin is part of RBCs, which take 120 days roughly, that's their lifespan. So when you check the levels of this sugar, the one that is bound to HB, then you're seeing this patient's sugar control for the duration that these cells have been in existence, okay, which is about 3 months. So if the sugar that is bound to RBCs is high, then you would know that, okay, it has been at this level for the time that these RBCs have been in the body. And because RBCs have a lifespan of about 120 days, then that is how we arrive at the 3 months that we talked about earlier. I hope that has made sense. But in simple terms, in case that didn't make sense, HbA1c is for long-term control. You use it to measure long-term control of sugars. Question 7. Which of the following symptoms is most likely to be associated with hypoglycemia? So a symptom that will most likely be associated with hypoglycemia. All right, good question. Good question here. Polyuria. Polyuria is a symptom of hyperg. Okay, so is polydipsia. So is polyphagia. So these three are just there to confuse us. Let's consider weight loss and diaphoresis. So in a chronic setting, yes, when the sugar levels are low for a prolonged period of time, then you expect the body to start using other sources. Gluconeogenesis, generally the body may start using other sources. So when sugar levels are low, what can happen? Diaphoresis or weight loss. So in this case, in the immediate setting, it's diaphoresis. Remember how you may feel some palpitations or tremors, just shaking. Even confusion can happen when you're like really hungry, case of hypoglycemia. That's why hypoglycemia is really bad. Weight loss can be a good point there because when sugar levels are low, the body may choose to use breakdown fat, breakdown proteins, which may lead to weight loss, but that is in a chronic setting, like over a long period of time. The question here is mostly referring to like what would happen like in the immediate setting. So going for weight loss would be a stretch, of this scenario. So diaphoresis, this is just very practical. It's you become diaphoretic when sugar levels are low. Question 8. Which lifestyle modification has the greatest impact on reducing the risk of developing type 2? So there are certain lifestyle modifications that will help, reduce the risk of developing type 2 diabetes. So which one is it? A, reducing salt intake. B, regular physical activity rather. C, avoiding gluten. D, drinking more water. E, increasing dietary fat. All right. Reducing salt intake is a good consideration in hypertension. Regular physical activity is good for diabetes, but let's wait. Gluten, not in hypertension. Drinking more water, well, not really. We're looking at what will reduce the risk of developing type 2 diabetes. I mean, drinking enough water is always good. It's always good. The body needs water, but not necessarily that it will reduce the risk of developing type 2 diabetes. Increasing dietary fat, not necessarily. So it's regular physical activity here. So regular physical activity improves insulin sensitivity. Remember how in type 2 diabetes, the problem is that the body is not as sensitive to insulin as it should be. All right. So the insulin is there, but it's not able to do its job because the receptors are not that sensitive to it. So regular physical activity can help with that. Which of the following is a characteristic feature of diabetic retinopathy? So diabetic retinopathy, remember how the eyes, blindness is one of those long-term complications, and the cause of that blindness is retinopathy. So what is it exactly that is responsible for that? A, microaneurysms. B, macular degeneration. C, glaucoma. D, cataracts. E, optic neuritis. So here the main problem is the patient will have microaneurysms, option A. All right. So microaneurysms will be the characteristic feature that you'll find. Microaneurysms will be that characteristic feature that you'll find. And there'll be other things now: hemorrhages, exudates, neovascularization, and microaneurysms will be like the earliest sign, and all that. So microaneurysms there for retinopathy. Question 10: which oral antidiabetic drug class is most associated with weight loss? Oral antidiabetic drug class. Okay, so you're talking about oral antidiabetics. Now, which one of them is associated with weight loss? All right. So sulfonylurea says thiazolidinediones, DPP4 inhibitors, SGLT2 inhibitors, and meglitinides. So it's SGLT2 inhibitors. So they typically promote glycosuria, and that leads to weight loss. All right. So that is the one. All right. So SGLT2, the name may sound like weird, but these are just sodium glucose co-transporters. So yeah, that's the name. What's the primary action of insulin in the body? Well, insulin, what does it do? Promotes glucose uptake into cells. This is a question which, when you find it, you're even celebrating. Yeah, found a good one. All right. Question 12. A 35-year-old woman with type 1 diabetes experiences morning hyperglycemia. Which phenomenon is most likely responsible? What phenomenon is this why a patient has hyperglycemia in the morning? So this is what we call dawn phenomenon. Dawn phenomenon. And with dawn phenomenon, you have increased morning blood glucose levels. And the reason is, as the body is preparing to wake up, the levels of growth hormone and cortisol increase, and the body kind of, prepares for the day by increasing, the sugar levels with these hormones. So that is dawn phenomenon. Okay. Which of the following is a diagnostic criterion for DM? So diagnostic criterion for DM, all right? A, fasting plasma glucose of equal to or greater than 5.6 millimoles. B, HbA1c greater than 6%. C, 2-hour plasma glucose, which is greater or equal to 11.1 millimoles per liter on oral glucose tolerance test. Then RBS of greater than 10. Symptoms of diabetes with fasting glucose of greater than 110. So this is an interesting question. It is an interesting question. So here you're going with an OGTT of 11.1. So 2-hour plasma glucose, that is 11.1. That is the one that you're going with. So this one is diagnostic of DM. Question 14. Which microvascular complication is most closely associated with DM? So microvascular complication most associated with DM. A, stroke. B, myocardial infarction. C, peripheral artery disease. Nephropathy, hypertension. So here you're working with diabetic nephropathy. This is a common microvascular complication. Which of the following is the main goal of managing DKA? Lowering blood pressure, correcting hyperkalemia, rehydration and insulin therapy, preventing hypoglycemia, treating underlying infection. So the blood pressure, this question is just coming back. I think we did something like this when we were considering DKA questions. So lowering blood pressure, not really. Correcting hyperkalemia. Actually, what you're worried about in this case is hypokalemia, not hyperkalemia. C, rehydration and insulin therapy. This is your answer here, okay? You want to rehydrate the patient, and then you want to, initiate insulin therapy. So fluids, remember how it's fluids? Usually it's abbreviated as FIPA or FIPA. the main considerations that you have when treating a patient with DKA. FIPA, F for fluids, I for insulin, P for potassium, you want to correct potassium levels, and A for antibiotics. So rehydration and insulin therapy. All right. Which hormone opposes the action of insulin? High school biology, grade 10, 11, 12. Glucagon, that is the one that opposes that. Question 17. A 55-year-old male with type 2 diabetes mellitus presents with painful neuropathy. All right, painful neuropathy. Which medication is recommended for pain management? So in a setting such as this, where you have diabetes and painful neuropathy, what is given is amitriptyline. So amitriptyline is what is given in this case, all right, for painful neuropathy. This is the one that is used. Okay, it's a tricyclic antidepressant, and it's used in this setting. What is the first line treatment of diabetic nephropathy with proteinuria? Interesting. So diabetic nephropathy with proteinuria, the drug that is used for that, use ACE inhibitors. Okay, use ACE inhibitors. So you don't want the glomerular pressure to be so high, leading to loss of protein. Loss of protein. So that is the principle. Question 19. Which of the following is a risk factor for developing type 2 diabetes? Young age, high HDL, lean body mass, sedentary lifestyle, low blood pressure. So a sedentary lifestyle is a huge risk factor. Remember, we dealt with a question that was asking us what change is the most significant in terms of improving one's insulin sensitivity. We dealt with a question that was similar to that, and physical activity was the top option. So when you increase your physical activity, you're working a lot, the body's sensitivity to insulin improves. And when the body's sensitivity to insulin improves, your chances of developing type 2 are low. So that is the understanding there. That is the principle. So normally a sedentary lifestyle is where a person just, mostly they are inactive. They're at home. From home to work, they're driving. When they reach their place of work, they are seated all day, come back from work, go back home. They're sitting, they sleep, the cycle continues. They don't have any physical activity at all. So for those, introducing some level of physical activity would definitely be helpful. Okay, would definitely be helpful. So that is the correct one there. I think we're going to end here for this session. Thank you very much for your attention, and all the best as you prepare for your exams.